Assalamu alaikum students and welcome to yet more ophthalmology. What can we do? We do ophthalmology in the ophthalmology clerkship. Today we are starting off with thyroid eye disease, which is a double word differential in our last theme, which is ocular deviations. As the name suggests, ocular deviation is a theme that deals with when your eyes are no longer aligned. And in thyroid eye disease, we see two types of deviation. One in which the eyes are popping out, which is called proptosis or exophthalmos, and the other, a more traditional definition of deviation in which the eyes with respect to one another don't maintain alignment, which is called strabismus or squint. We see both of these things or both of these presentations in thyroid eye disease. So this is what we are going to be doing today. We'll start off by talking about the relevant structure and function of the tissues involved. Then we'll talk about definition, etiology, and pathogenesis of thyroid eye disease. How do patients present, and finally diagnosis and management of the condition. So let's talk about the relevant structure and functions of the tissues involved, which is the ocular adnexa and the extraocular muscles. So the first thing we need to do is to, we have seen a picture like this before, is to basically determine the position of the upper and lower lid, specifically the upper lid. And we have talked about this before, that the upper lid covers the upper 2 millimeters of the cornea, and the limbus, superior limbus, is thus not visible, as can be seen from this picture here. So this dotted arc represents the part of the cornea and the limbus that's sort of covered by the upper lid. The lower lid rests at the limbus, so you can just uh, have a, you can just see the limbus, or the limbus and the lid are sort of aligned with one another. The lashes in the upper lid are pointed upwards and outwards. For the lower lid, it's downwards and outwards, and the puncti, which is the beginning of the drainage system, are flush with the eyeball. So this is the anatomy of the extraocular muscles. They arise by and large from the annulus of them, which is this fibrous tissue, with the exception of inferior oblique, which arises from the medial side of the floor of the orbit. So this is a picture on the right where the eyeball has been removed. You can see the muscles arising from this fibrous tissue, and they sort of spread out and attach themselves onto the eyeball. And we'll just see how that happens in the next animation slide. So the muscles on the medial side of the medial rectus and superior oblique. Superior oblique passes through this structure, which is called the pulley, and attaches to the superior lateral half of the eyeball, superior, posterior, and lateral. The inferior oblique arises from the floor and attaches itself into the inferior, posterior, and lateral half of the eyeball. The other recti attach themselves to the eyeball, as their name suggests. So lateral is on the lateral side, medial is on the medial side, superior is superior, inferior is inferior. LPS is levator palpebris superioris, which is the muscle that attaches itself to the tarsal plate of the upper lid as well as the skin. It helps to open the upper lid or raise or elevate the upper lid. So this is a little animation, and we have seen this animation before um, when we were talking about orbital cellulitis. So this is inferior oblique, inferior rectus, lateral rectus, levator palpebris superioris, underneath which is superior rectus. This is the pulley and superior oblique, and this is that annulus of Zinn where these muscles or originate from. And you can see that the optic nerve is in very close association. We've talked about this when we were talking about optic neuritis. We've seen this animation in optic neuritis before. I don't think it was cellulitis. I think it was seen in optic neuritis when we were talking about optic neuritis. So these are the muscles, and these are the locations in which they attach. The important bit today is to show you the close association of the nerve with the origin of the muscles, because that'll sort of become important as we talk about this disease. So this is another picture of the extraocular muscles, and we are looking at the orbit with the roof removed. So we are looking at the superior rectus, we are looking at the orbital adipose tissue, we are looking at the recti muscles, the horizontal recti here. This is the optic nerve right here, and this is the orbital fat right here. And as you can see that the orbit is a pretty packed structure uh, with muscles and orbital fat and the eyeball. This is the structure of the upper lid, and we have seen this picture before. We were talking about ptosis, and I believe also when we were talking about ocular surface, and lid anomalies. The area of interest today is this Muller's muscle, primarily the Muller's muscle, which is an elevator of the lid. And this is the Muller's muscle. It is a muscle that's driven by the sympathetic system, and it helps to provide a little bit of elevation to the upper lid, or sort of minor elevation to the upper lid. So these are the muscles that are involved. This is our area of interest today, the Muller's muscle right here. Orbicularis oculi obviously helps in closing of the eyelid, while levator palpebris superioris and Muller's muscle assist in opening the eyeball, opening the eyelid, the upper eyelid, to be more accurate and precise. Because there is no levator palpebris superioris in the lower lid, there is no Muller's muscle in the lower lid. So these are upper lid elevators, levator palpebris superioris and Muller's muscle. This is an MRI of the orbit, and this is showing you the structure of these muscles. And as we saw before, well, it was written before, I didn't talk about it, that these muscles, despite being skeletal muscles, don't have that typical fusiform shape. They are mostly strap-like. They're like, pieces of straps. This is sort of important because of reasons that we'll just talk about in a bit. This is just showing you that there is some mucus thickening, but that's not of our interest. Our interest is just the normal appearance of these extraocular muscles. Now we're going to be talking about the disease definition, the etiology, and pathogenesis. Thyroid eye disease has been defined in various ways using various different terms, Graves' ophthalmopathy, thyroid-associated ophthalmopathy, but the general term that's sort of agreed upon these days is called thyroid eye disease. And thyroid eye disease refers to any eye condition that's associated with any type of thyroid dysfunction. Most of the time, it is associated with hyperthyroidism, 90% of the time, of which Graves' disease is the most common. 50% have Graves' disease. Graves' disease is basically immune-mediated increase of thyroid hormones. 10% of thyroid eye disease is associated either with a normally functioning thyroid gland, which is called euthyroid eye disease, or hypothyroidism. For example, Hashimoto's thyroiditis, in which after a brief period of a thyroid storm, the patient goes into a hypothyroid state. So the damage to the eye could have occurred during the thyroid storm stage, but technically it is still defined as hypothyroidism. But most of the time it is associated with a hyper-functioning thyroid gland, and most of the time the disease is Graves' disease. The definition of thyroid eye disease is an autoimmune inflammatory condition that involves the orbital tissues, primarily the orbital fat and the orbital muscles, and it tends to spare the muscle tendons and involve the muscle bellies. And that is where the thing that we talked about before, the muscles normally being strap-like, is important, because we'll see how they actually change their shape in response to this disease process. As I said, it's also been called Graves' ophthalmopathy. If it's associated with Graves' disease, it's also called dysthyroid orbitopathy and thyroid-associated ophthalmopathy. So various terms, but the term used these days, the generally agreed upon term, is called the thyroid eye disease. So the risk factors for thyroid eye disease are genetic and immune factors, including and also environmental factors, especially smoking, which is really important, and the general level of stress. These are the demographics. It's way more common in females than males, and maybe by as much as 4 times common. It usually has a bimodal presentation. It's the median age of patient presentation is usually 43 years. The first range of age where it usually presents is between 40 and 44 years, and then the other age group is between 60 and 64 years, bimodal presentation, but it can occur anywhere from 8 to 88 years of age. So what happens? Actually, the real reason is unknown, like most diseases that we have talked about, but it's presumed to be because of activation of orbital fibroblasts by Graves' disease associated or thyrotropin receptor, TSH receptor antibodies, and they cause various changes which actually lead to thyroid eye disease. The exact cause is not known, but it is assumed to the factor or the point where it all starts is when fibroblasts within the orbit are activated because of TSH receptor, which is a thyrotropin receptor autoantibodies. And what it does is it basically causes T cell activation within the orbit and initiation of the inflammatory cascade there onwards. Because it's an inflammatory process, you have production of extracellular matrix molecules, glycosaminoglycans, and water, And with it, you have orbital adipogenesis. Remember, we saw fat pads within the orbit when we were talking about the structure and function, the tissues involved in this disease. And you have a lot of fat production within the orbit, and that is one of the causes of the major issues with this disease. You also have a lot of edema simply because you have inflammation going on. So you have soft tissue edema, including orbital edema. And then finally, you have inflammation and lymphocytic infiltration of your extraocular muscles. So all of these things presumably start off when orbital fibroblasts are activated. And it has a very peculiar sort of a progression, as we'll see graphically as well. You have an active phase of inflammation, progression of disease, a really quick phase of inflammation, and then the disease slowly sort of progresses between about 8 and 36 months, and then it sort of stabilizes and improves. And sometimes this is it. This is all you get. You get one cycle of rapidly progressive symptoms, then sort of slowly progressive symptoms. That is, disease sort of tends to sort of has found its peak, and it continues at that level, and then it sort of starts stabilizing. Symptoms start improving. Depending upon how severe the disease was, the patient might end up with just as he started off, with no real morbidity, or he could even end up losing his vision um, just in one cycle. But the thing is that although not very common, this cycle may restart later on. So if a patient has one cycle and he sort of come out of it without any morbidity, it does not mean that's the end of the disease. Might end up in another cycle. So how do these patients present, and what is this cyclical change or cyclical disease pattern that we talk about? It is a bilateral disease, obviously, because it's a systemic disease, but it is because of a systemic disease or a change in systemic levels of systemic hormones. But it can, as we talked about, also happen in a patient who has no thyroid dysfunction. So it's a bilateral disease with highly asymmetrical presentation. In fact, the number one differential diagnosis of proptosis, as we'll talk about what proptosis is, and I'm sure you know what it is, the number one diagnosis of unilateral proptosis is still a thyroid eye disease, in spite of the fact that thyroid eye disease is a bilateral disease, but it is a very, very asymmetrical disease. So, in mild disease, something in which the patient might come out of without any morbidity is a gritty sensation, foreign body sensation, tearing, and photophobia. We'll just see why that is. It's basically because of soft tissue edema and lid edema. For a moderate to severe disease, that happens when you have proptosis. You can have pain, you can have a lot of redness, and this pain and redness could be because of exposure, as we'll see. The patient might end up in diplopia because the muscles sort of stop working, and decreased vision because the optic nerve starts getting compressed because there is not enough room in the orbit when orbital adipogenesis or fat production starts, and the orbit is full of enlarged muscles, and on top of it, inflammatory exudate, glycosaminose glycans, and water accumulation. So we'll see how that happens. So this is one way of remembering the patient's signs. Although it's an older system and might not be very popular among ophthalmologists or even endocrinologists, more importantly, it is still something that's very relevant to undergraduates. So when the patient is in this half, the upper half shown in blue, this can be defined as a mild disease, or a disease in which the patient might come out of without much morbidity. And these are the symptoms experienced. And the good part is half the patients only sort of have these symptoms and don't sort of progress beyond this. These symptoms are seen in about 3 to 5% of the patients. So many patients might not even present at all, in spite of the fact that they have a thyroid eye disease, because the presentation is so mild. So these are mild to moderate to severe disease signs: proptosis, extraocular muscle restriction, corneal opacity, sight loss. And the symptoms that are associated with this are going to be the symptoms of what the patient is already experiencing, and on top of that, pain, redness, diplopia, and decreased vision. This is the curve I was talking about. This is called the Rundle's curve, and this is a little bit modified presentation of the curve. This is the disease severity, and this is the time. Remember, it's about 8 to 36 months that the disease lasts from. So if you have a mild disease, and this line right here, the line shown in purple, is showing you the how quickly the symptoms tend to rise, and then they sort of stabilize, and then the patient sort of starts improving. So if you have a mild disease, the disease is usually of a shorter duration, and within 3 to 6 months, the patient is pretty much okay. And the patient, as you can see from this blue line here, he ends up without any significant morbidity, and he's going to probably see only lit signs, as we'll just talk about what lit signs are. In moderate disease, obviously the disease is going to be of a little longer duration, and there would be might be a little bit of morbidity involved, but you would mostly see lit signs and soft tissue signs. In marked and severe disease, we are talking about proptosis, extraocular muscle restriction, and maybe sight loss. And as you can see, the disease duration is longer, and the patient does end up with significant levels of morbidity. This line here, the line that's at the end right here, is representing where the patient returns to. So in mild disease, the patient pretty much returns to normal. In moderate disease, there might be a little bit of morbidity. In marked and severe disease, there's significant levels of morbidity. Depending upon how severe the disease was, the morbidity could include losing all of your vision, i.e., becoming blind. So an active disease where the symptoms rise sort of very quickly, a static disease where the symptoms have sort of leveled out, symptoms and signs both, and then a burnout disease in which the disease is now sort of dying off and the patient is improving. Where the patient ends up is basically dependent upon the severity of the disease, which is shown in the y-axis. So the shorter the duration of the active phase, the less severe the disease and the better the recovery and the quicker the recovery. So let's start off with our classification system, because remember, this is how we are going to see our patients, and they're going to fall into any one of these categories from no signs all the way to sight loss. So the first category of patients is patients with no ocular signs. And these patients are those who are going to present to their endocrinologist or family physicians with systemic signs of thyroid dysfunction. So right now, your family physician, your internist, your endocrinologist, these are the important players, and you as fresh graduates and family physicians are responsible primarily to educate your patient that right now you're in a stage where your eyes are not involved, but your eyes can get involved, and these are the things that you might expect. So you should go see your ophthalmologist, or you refer him to your ophthalmologist, um, because family physicians obviously have a network of specialist doctors, because that's what you do. You're gatekeepers to the health system. So you refer the patient to an ophthalmologist just for a baseline evaluation, or you tell them you go as and when the need arises, depending upon uh, the patient. Is he willing to go? Would he like to delay it? So you right now, it's not necessary that an ophthalmologist sees a patient, because the patient, you can tell, I'm sure, even as family physicians after going through the ophthalmology clerkship at IMDC, that yeah, this patient has signs or symptomatology of thyroid eye disease. You have to, or getting through ophthalmology is not going to be easy for you. Anyways, so just for the systemic evaluation, you need to go through the complete endocrinological examination of the system, do the relevant investigations, thyroid function test. But right now, the domain is family physician and endocrinologist. The ophthalmologist hasn't stepped in yet, because there are simply no signs involving the eye. So, as I said, it's effective communication, possibly telling the patients of symptomatology that might occur if the eye starts getting involved, and then telling them you should go see the ophthalmologist if you see these signs, or come see me and I'll refer you to the ophthalmologist. From that stage, we move on to the O stage, which is only lit signs. This is the earliest form of the presentation, and it is also the most common form of presentation. 91% of individuals who have thyroid eye disease have only lit signs. And this is basically due to Muller muscle overactivation. Remember, Muller's muscle is a minor elevator of the upper lid. It's a sympathetically driven muscle, and what happens in thyroid eye disease is that you have thyroid overstimulation and exacerbation of sympathetic nervous system response, which causes overactivity of the Muller's muscles, which Muller's muscle, there's only one, which makes the eyelid open more than normal. Your eyelids are retracted. I'll show you what that looks like in a bit. The retraction together with lag are both associated with Muller's muscle overstimulation. So eyelid retraction is simply a higher than normal resting place of the upper lid. It's also called Dalrymple sign. Yeah, I know, but some examiners like this term. Eyelid lag is when you're looking down, the upper lid sort of lags behind the eyeball in rotating downward, simply because the Muller's muscle is not letting the eyelid move downwards. It's overstimulated. That's called the von Graff's sign. And then the symptoms here are because of exposure and dry eyes. We have already talked about dry eyes, so I'm sure you're aware of the symptoms. It's a foreign body sensation, gritty sensation, watering, redness, and photophobia. Photophobia because of disruption of TFL, watering because of excessive evaporation of TFL, because the eyes don't grow, don't close properly, don't close properly, and a little bit of redness because of exposure again. So this is what lid retraction looks like. And as you can see the superior limbus. Normally you can't see the superior limbus because the upper lid covers it. And this is a very sort of symmetrical bilateral lid retraction. If I can bring in the normal picture, this was the normal picture in which the upper lid covers the upper 2 millimeters of the cornea. So you can't see the superior limbus. Here you can see the superior limbus, and this is what lid retraction is. This is asymmetrical retraction. You can see the left eye has significantly more retraction than the right. You can still see the limbus in the right eye, but you can also see a clear sclera in the left eye. So you have asymmetrical retraction. This is lid lag, and the picture A is basically showing retraction. B is showing lag, and as you can see, only in the right eye, both of these conditions. As the patient is asked to look down, in the left eye, the lid follows the eyeball. In the right eye, the eyeball has rotated down, but the lid is still lagging behind it. You can see a lot of clear sclera in between the lower margin of the upper lid and the eyeball. And this is simply because the molars muscle is not relaxing enough to let the lid move downwards together with the eye. So the eyeball and the lid have become desynchronized. The eyeball can right now rotate downwards. Nothing's wrong with that right now. But because of Muller's muscle overactivity, the lid sort of lags behind it. And again, you can see this is very asymmetrical. The left eye is perfectly fine. The left eye shows no retraction. The right eye shows retraction as well as lag. Now we are moving on to the third stage, which is soft tissue signs. And soft tissue signs occur because of soft tissue edema. We have conjunctival chemosis, in which we have conjunctival congestion, redness, and edema, which is called the Goldzier sign. Yes, I know another term that nobody likes to remember, but hey, what can you do? And lid edema, which is edema in your lids, which is because of soft tissue edema. You also have a condition called superior limbic keratoconjunctivitis, and since your conjunctiva is edematous, your lid is edematous, they are closer to one another and they are rub against one another because of increased friction, and they get a little bit of inflammation in the superior part right here of the conjunctiva and the limbal area of the cornea, which is called superior limbic keratoconjunctivitis, or SLK. I'll show you some pictures. Thyroid eye disease is mostly history and clinical presentation of a patient, i.e. pictures. So the symptoms are going to be very similar to what you saw before. They will just, now continue to worsen. So this is what conjunctival chemosis or edema looks like. And as you can see that because of lid edema, the retraction is now masked because the lids have become heavy and edematous. So they are sort of they don't appear retracted because they are edematous and heavy. And they have sort of returned to normal position or normalist position. This can also be said to be slightly ptotic at this point in time, the right lid. But let's just say that they are not retracted. This is superior limbic keratoconjunctivitis, and as you can see, the superior conjunctiva together with the limbal area has inflammation. Remember, cornea is avascular, as is limbus. Now we have these fine vessels across the limbus. You can say pannus formation. We did pannus formation when we talked about keratitis. So this is again because of friction between the lid and the conjunctiva, both tissues being edematous. This edema is not as marked as the edema here, but still you can see there is some level of congestion in the blood vessels of the conjunctiva in this area. And this basically occurs in the superior area because this is the point where the lid and the eyeball have the closest contact to one another. And because they are both edematous, that is now closer, and because of friction, you get superior limbic keratoconjunctivitis. This is bilateral superior limbic keratoconjunctivitis. You can see a little bit of thickening as well, in addition to congestion. And obviously the patient is looking downwards. That is why you have such a clearer view. We are now talking about signs that classify the disease as moderate or severe, and we'll start off by talking about proptosis. which occurs because of orbital adipogenesis and orbital edema. The orbit has a fixed volume. It's all bony, with the exception of the eyeball that's in front, which has a lot of rigidity to it. So when you have adipogenesis and orbital edema, the orbit can't expand, so that the eyeball gets pushed forward because the bones obviously can't expand. The only structure which has a little bit of malleability is the eyeball, so it starts getting pushed forward. And this is seen in 60% of the patients who have thyroid eye disease. Now, there's another term called exophthalmos, and exophthalmos is a term that's specific to the eye. Proptosis is a general term that is used to describe any body structure that is protruding forward. Exophthalmos is specific to the eye and very specific to thyroid eye disease, and it is clinically visible when the corneal apex is in front of the plane of the brow. It can be measured using a scale or an exophthalmometer, and we'll see how that is done in a bit. It is also important to be able to differentiate proptosis from lid retraction, and that's one of the reasons that proptosis is ideally examined from the side and not the front, because it might appear to somebody who is just starting to examine patients of thyroid eye disease that this is lid retraction, when it can actually be proptosis, or the other way around as well. The symptoms that the patient experiences are worsening symptoms from before: gritty sensation, foreign body sensation, watering, redness, and photophobia, i.e., symptoms of exposure. Now, what is going to happen is the patient will experience pain simply because the eyeball is getting pushed forward by increasing orbital volume in the form of increasing orbital fat and orbital edema, deposition of gags and accumulation of water. The patient will also start having issues with the vision. But since this is initially a problem with visual field, so the patient might not notice this. And this is happening because of compression of the optic nerve, because of the increasing orbital volume compressing the optic nerve. So the patient will have eventually features of optic nerve compression apparent to him in the form of loss of visual acuity. Because remember, most of the time we rely on visual acuity and not on the visual field. And the compressive optic neuropathy starts off with loss of the visual field, which obviously initially is going to be very minor and may be not noticeable by the patient. So it is very essential that when you get a patient of proptosis, you get a visual field done to see whether the compression of the optic nerve has started or not, and also do the other functions, optic nerve functions. We'll just talk about those when we talk about diagnosis and management. This is what proptosis is, and looking from the front, it could be proptosis or lid retraction. It's only from when you see from the side and you see the orbital apex in front of the plane of the brow that you can say, yeah, you're looking at proptosis or exophthalmos. You measure it with a scale. You put the scale at the lateral canthus, the outer canthus of the eye, and you make sure it's parallel to the eyeball, and you measure where the corneal apex is. This distance should be between 14 to 21 millimeters, 14 in Asians, 21 in Caucasians. And if you see asymmetry of more than 2 millimeters, that can be classified that can be classified as exophthalmos. But if you should have a scale with you, but clinically apparent exophthalmos is when the cornea is in front of the plane of the brow, the corneal apex to be more precise. This is an exophthalmometer. This is a proper instrument that can measure this for you without a scale. It has a mirror here, so you can take the reading of both eyes, and this is the scale. It is important to figure out that, although the number one differential of even unilateral proptosis is thyroid eye disease, there are other possibilities that also lead to a proptosis. So what you need to think of is something that is increasing the volume of the orbit, in addition to what is happening in thyroid eye disease, and then think of intracranial abnormalities that might have a secondary effect on the orbit. And if you put those two together, if you put these two things together, these are the 5 things that you come up with: optic nerve gliomas, which are slow-growing tumors of childhood; vascular tumors of the orbit. Rhabdomyosarcoma is sort of important. This is a tumor that arises from the mesodermal tissue that forms the extraocular muscles. It is sort of a rapidly developing proptosis most of the time, and it is usually a unilateral condition. It's seen in young patients, young males between 7 and 8 years of age. Carotid cavernous fistula is something that can cause proptosis simply because of dilating vessels within the orbit, and intracranial tumors can have a secondary effect on the orbit as well. So this is an optic nerve glioma. This is a scan showing the large glioma, and this is the proptosis. This is rhabdomyosarcoma, which is a very quickly developing, rapidly developing, generally a very rapidly developing. It can be slowly developing as well, but most of the time it is a very rapidly developing proptosis. This is the scan showing the rhabdomyosarcoma. It is actually the most common sarcoma of the orbit, and it's usually seen in the young age. Moving on to the next stage, which is next sign is more appropriate, which is extraocular muscle restriction. And this happens because you have lymphocytic infiltration of your extraocular muscles together with their inflammation, which makes, and this inflammation and infiltration is something that spares the muscle tendons and only affects the muscle bellies. So your muscles take on a fusiform shape. I'm sorry, I was just fixing something. Sorry for that little bit of my hand moving away. Anyways, so extraocular muscle restriction occurs because of inflammation and lymphocytic infiltration of the extraocular muscles, and they become fusiform because it's only affecting the muscle belly and the tendons are sort of spared. This is seen in 43% of patients with thyroid eye disease. The most commonly involved muscle is the inferior rectus, and since the inferior rectus has to relax if the eyeball has to rotate upwards, and since it's become fusiform, it does not allow the superior rectus or the elevators of the eye to act. So you have a problem with elevation. It might sound a little bit strange, hey, if the inferior rectus is not working, the eye shouldn't be able to look down, but actually the inferior rectus is restricting the actions of elevators of the eyeball, so the eyeball can't turn up properly. So the problem is mostly in the up gaze rather than the down gaze. The symptom patient experiences include diplopia, and this diplopia could be in one gaze or more than one gaze. It is usually the up gaze that's affected first for the reason that we've already mentioned, but depending upon the number of muscles involved, you could have diplopia in more than one gaze. The patient would obviously have symptoms that he is carrying over from the previous stages of the disease, which is pain, worsening, foreign body sensation, gritty sensation, watering, photophobia, which are generally symptoms of exposure, and then worsening vision in terms of worsening visual field and or visual acuity, depending upon how much damage has been done to the optic nerve because of the effect of compression because of orbital edema and now muscle enlargement. These are the various types of muscle restrictions that can be seen, with the elevation defect being the most common, shown by the picture on the top left. The rarest is an adduction defect, which is shown by the picture on the bottom right. This is an MRI showing you fusiform enlargement of the muscle belly. Notice how the tendons are sort of their normal proportion, but the bellies have become extremely enlarged. This is how the normal muscles appear, and they are pretty much very strap-like. As you can see in this picture on the left, on the right, you can see the fusiform enlargement of the extraocular muscles. These are the various pictures that are showing you various manifestations of the effects of enlargement of extraocular muscles. The first one being, i.e., picture A, top left, showing you elevation restriction. The left eye can't elevate, the right eye elevation is sort of restricted. Picture B is showing you fusiform dilatation of the muscle bellies. You can see it very clearly, and it's indicated by black arrows. Picture C is showing you a dissected specimen and again fusiform enlargement of extraocular muscles, and picture D is lymphocytic infiltration of the extraocular muscles. We are moving on to the next stage, which is corneal opacity, and corneal opacities occur because of something called exposure keratopathy. And exposure keratopathy is a term that encompasses everything that happens to the eye because of abnormal exposure. Started off with lid lag and lid retraction when you had a little bit of exposure, and when proptosis sets in, this exposure gets worse. Now it's gotten so bad that it started producing very severe symptoms, much beyond just foreign body sensation, photophobia, irritation, watering. And what is happening now is your cornea is starting to get damaged because of dryness, and which is because of exposure. The tear film does not cover the cornea. It has no protective barrier over it from the environment, and it starts getting damaged. And the extent of damage would obviously depend upon the severity of the disease and whether appropriate interventions has been done at appropriate times. But it could be severe enough to cause blindness in a patient. But this blindness is reversible because it can be remedied by keratoplasty. But obviously, keratoplasty would only be effective if the optic nerve function is still sort of intact and the optic nerve is not so severely compromised so as to the fact that that is the reason for the decrease in vision, in addition to obviously corneal opacities. But keratoplasty is only done once the disease has sort of stabilized. The symptoms are obviously going to be worsening symptoms of exposure, which is worsening foreign body sensation, gritty sensation, watering, redness, photophobia, worsening visual field and visual acuity because of the effects of compressive optic neuropathy, which is happening because of orbital adipogenesis, orbital edema, and enlargement of extraocular muscles. Diplopia because of muscle loss of appropriate muscle function, as we just did in the last stage, and blindness. And that blindness can be because of corneal scarring secondary to exposure, and it can also be because of optic atrophy, because of long standing compression of the optic nerve. Let me just show you a picture, and this is how severe the condition can be. And this is obviously a very severe representation, but this is a possibility. You can have both corneas so extremely opacified because of exposure that the patient cannot see anything, even if the optic nerve is functioning normally. And this is basically because of exposure, and this appearance is basically called exposure keratopathy. Obviously, this is one very extreme representation of exposure keratopathy. It can be just a few corneal epithelial defects, corneal ulceration, but these scars are a very extreme representation. But it's been shown here to show you what the disease can do to the patient if appropriate management is not done. This is the last stage of our classification system, which is sight loss. And this is permanent visual disability because of compression of the optic nerve, which started off when the orbital volume started increasing because of adipogenesis and orbital edema, when proptosis started. And it obviously gets worse as the disease progresses, and it is further sort of accentuated by the enlargement of the extraocular muscles. The symptoms that the patient experiences would be worsening symptoms from before, worsening symptoms of exposure, foreign body sensation, gritty sensation, watering, photophobia. Um, the patient may or may not experience diplopia depending upon the extent of visual loss. So that is something that would be dependent upon how badly is the visual function compromised. Uh, the vision would obviously be worsening visual field and visual acuity because of again compressive optic neuropathy. What are the specific signs of optic nerve compression? You have visual field effects or decreased visual acuity depending upon the severity of the disease. Visual fields are obviously affected first. Visual acuity is affected after. RAPD would be seen in case of asymmetrical disease, and remember, thyroid eye disease can be very asymmetrical. In fact, so much so that unilateral proptosis is the number one differential for unilateral proptosis is thyroid eye disease. Red desaturation, we have talked about red desaturation when we talked about optic neuritis. You have the most prominent cone or the most numerous cone is the red cone, or the cone that picks up or is sensitive to the red frequency. And as you start losing your optic nerve function, the red function is lost the most because they are the most prominent, the most numerous cones. So the patient starts experiencing a little bit of desaturation of red color. Red appears as pink. Obviously, long-standing compression would obviously lead to optic atrophy. We talked about optic atrophy when we were talking about optic neuritis. But you need to have clear visualization of the fundus to actually see optic atrophy, or even RAPD for that matter. So now we are coming on to the diagnosis and management phase of our discussion. The diagnosis is basically based on history and clinical findings. You can do visual fields to document effects of the compression of the optic nerve or the effects of compressive optic neuropathy. Supportive evidence would obviously include thyroid function tests, but remember you can have euthyroid disease in which the thyroid is normally functioning and you have all of the associated issues with the eye that you see with in thyroid eye disease. MRI orbits would help you identify muscle issues, enlargement of muscles, and also increase amount of fat or adipogenesis. But again, it's history and clinical that establishes a diagnosis of thyroid eye disease. Management is again very complicated. It's very complicated because it involves a lot of specialties and it requires very good communications among those specialties and also between those specialties and the patient. The primary care physician or the family physician is obviously going to play the major role because he is going to be tying all of these specialties together. He is basically going to be responsible to ensure that whatever the other physicians are doing, they are in the know as to what the other person is saying, so that everybody is not blind to everybody else. So it's not that the patient is getting the same treatment from multiple places. So that is the role of family physician. And in addition to that, is also constantly communicating and explaining to the patient what's going on. And that is why you do thyroid eye disease in your graduate studies, your MBBS, so that when you graduate and you want to practice as a family physician or a general practitioner, you know how to do these things. And although you might not be treating a patient, you are keeping tabs on what other doctors are doing and explaining to the patient why are they doing what they're doing, and also ensuring that all the doctors are on the same page with regards to the management of the patient. um, the most important physicians here are your endocrinologist and your ophthalmologist. You might need to involve also other subspecialty of ophthalmology, including oculoplastics. You might also at times may want to involve a plastic surgeons depending upon what your needs and what your expertise are. The first thing to do is obviously to correct any underlying thyroid dysfunction. Remember that you can have thyroid eye disease with a euthyroid gland. And this is basically what the endocrinologist is going to be doing together with the primary care physician. Then you have your risk factors, of which number one was smoking. So cessation of smoking is something that is going to play a role in management of thyroid eye disease. For exposure, which is seen in the very initial stages of the disease, and also something that's seen in a very mild disease in which the disease really does not progress to proptosis or extraocular muscle restriction levels. Simply giving beta blockers to lower molar muscles activity together with preservative-free lubricants, tipping of the eye, and tarsorrhaphy could help. Tarsorrhaphy is obviously one extreme in which the patient has started experiencing early symptoms of exposure keratopathy. The cornea starts getting damaged. For orbital and adnexal edema, which was the sign after the lid retraction sign. So this requires salt restriction so that the fluid collection in the body reduces. You can also elevate head end of the bed, which reduces orbital edema. For diplopia, the aim is to ensure that the primary gaze, when you're looking straight ahead, and down gaze are all right, i.e., there is no diplopia in either of these two cases. And initially, when the patient is in an active disease, you give prisms. How do prisms work? We'll do that when we talk about squint, but they basically change the path of light so that the light falls on the fovea rather than extrafoveal elements. We'll also talk about how diplopia happens when we talk about strabismus. So if you're not clear about what diplopia is, we'll talk about it there as well. So you give prisms, and once the disease has stabilized, you can think about doing muscle surgery, which again we'll talk about when we talk about strabismus. This is tarsorrhaphy. We have seen this picture before in context of keratitis. This case, it's being done not to prevent corneal perforation, but to prevent effects of exposure. For optic nerve compression, the first choice treatment is oral prednisolone, 1 to 1.5 milligram per kilogram body weight for up to a period of 2 months. It works by reducing inflammation, which is basically the thing that produces all of the effects of thyroid eye disease, if you remember from when we were discussing the pathogenesis of this condition. It works. Why 2 months and why not more than 2 months? Simply because of the side effects of steroids. In addition to systemic side effects, you have the effects of cataract formation and glaucoma, secondary open angle glaucoma that can happen in the eye. So you need to ensure that while you're treating one disease, you do not make the patient suffer from another as a consequence of your treatment. So you have to, weigh the benefits versus the side effects of drugs. And for oral prednisolone, the safe period is about 2 months. If these oral steroids by themselves are not sufficient to control the compression, and compression, remember, is happening either because of increasing orbital volume because of adipogenesis and edema, something that also causes proptosis, together with enlargement of extraocular muscles. And both of these things are compressing on the optic nerve. So if by giving oral steroids, this can't be controlled, the second option is to use radiation. Radiation can be used by itself, and it can also be used in conjunction with steroids if required. Radiation is usually graded, it's given at about 200 centigrade per day for 10 days. And if steroids and radiation, both of them are unable to provide relief from nerve compression, the third option is orbital decompression. Orbital decompression is simply increasing the volume of the orbit by partially removing the bony orbital walls, starting off with the floor, then the medial wall, then the lateral wall. And the roof is rarely something that's removed to provide or to do orbital decompression. Decompression simply works by increasing the available volume of the orbit so that whatever edema or fluid is accumulating, it has more room to expand, giving the optic nerve some room to breathe and relieving the compression on it. For squint, which occurs because of restriction of extraocular muscle movement, that is occurring because of fusiform enlargement of extraocular muscles, you can do squint surgery, but it is only done after the disease is stabilized, no inflammation, no proptosis. Because once the disease stabilized, maybe there is no need to do squint or strabismus surgery anymore. For sight loss, it is really important and essential to protect whatever vision is remaining by allowing or doing one of the things that we have just talked about for optic nerve compression, either steroids or radiation or the combination of the two, or orbital decompression, and save the fellow eye, because it's really important that you do not forget that there is the other eye that needs to be saved. So the emphasis here, as I keep telling you, is not the disease, it's the human being behind the disease. So you just don't say to the patient, oh, we've lost this eye, we can't do much about it. You tell the patient, yes, the vision in one of the eyes is compromised, but we have the other eye, and we are going to do our best to ensure that the vision in that eye is preserved as much as we can. This table summarizes what we have discussed so far with regards to the management of thyroid eye disease. And at any stage that the patient is presenting to you, the first thing to do is to manage underlying thyroid dysfunction. If the patient comes in a no sign stage, i.e., no ocular sign, just a systemic sign, proper patient education, telling him or her, mostly her, about what possible changes can occur in the eye and what we can do about them, and how to sort of uh, pick up symptoms of those pathologies that can affect the eye. Those are all the things that you talk to the patient about when the disease is just beginning. So you tell them, oh, if you notice your eye is not closing properly, you need to see a doctor, and tell him or her that these are the things that can happen even beyond that. At this point, you might want to prescribe a preservative-free lubricant to the patient so that the patient knows that this is a drug that they will start using initially, and also that they can start putting in once they start feeling the effects of dryness. If the patient is coming to you in the only lid sign stage, lid lag and lid retraction, again lubricants, and they adding to lubricants is beta blockers. Beta blockers work by reducing the sympathetic outflow, and that would reduce the activity of Muller's muscle. Remember, Muller's muscle is responsible for lid retraction and lid lag, and prescribing beta blockers would reduce the activity of Muller's muscle, thus improving lag and retraction. You might also want to consider tarsorrhaphy if the patient is experiencing symptoms of exposure keratopathy, and the earliest symptoms would be worsening grittiness, dryness, photophobia, and the sign would be corneal erosion. So you might want to consider tarsorrhaphy here as well. Once you start getting soft tissue signs, those would be lid edema and conjunctival edema. Again, we are doing what we did for the previous stage, lubricants, beta blockers, and tarsorrhaphy, uh, just to ensure that, to minimize exposure, basically. At this point in time, you might also want to, reduce sodium intake and elevate head end of the patient so as to relieve and reduce edema as much as possible. Once you get to the proptosis stage, the biggest concern is optic nerve compression. So if you start seeing symptoms or signs, well, obviously you're going to see signs first of optic nerve compression. Uh, you need to proceed pretty quickly and follow up your patient very cautiously and carefully. And as long as the patient has proptosis but the optic nerve is not compromised, it is not experiencing effects of compressive optic neuropathy, supportive treatment is good enough. But once you have optic nerve compression, we need to ensure that it's relieved. So you can give oral or IV steroids together with radiotherapy if required, or orbital surgery decompression if the previous treatment is non-responsive. It's usually oral steroids that are given first. IV can be given in the form of methylprednisolone if oral steroids are not sufficient. For extraocular muscle restriction, which occurs because of fusiform enlargement, which is adding to optic nerve compression, which started off with proptosis because of adipogenesis and edema in the orbits, excuse me. For extraocular muscles, again, we are doing, sorry, oral or IV steroids to reduce inflammation and then orbital decompression if those are not sufficient. If you do see some remaining restriction once the disease has stabilized, you can do squint surgery. We'll talk more about squint surgery when we talk about squint strabismus. For corneal opacity, tarsorrhaphy, and you can consider keratoplasty once the disease has stabilized. And for sight loss, save the other eye and preserve whatever vision you can in the involved eye. This is the before and after picture of before and after comparison of orbital decompression. You can see the marked improvement in proptosis before and after surgery.